multifocal IOLs. And now we have Professor LAHANE, who is a big name in ophthalmology, and Padma Shri. Professor LAHANE is well known not only in Maharashtra but all over India, and we have been learning so much from him, and we know that he is a very, very hard working person. Even at senior citizen level, he is doing such wonderful talks, high volume surgeries all around Maharashtra. So over to Professor LAHANE, sir.
Thank you, Kamalji Singh sir. Now, SICS unaided in SICS. So what happens whenever we are thinking of the SICS, we always think this is an inferior surgery. But what we do in JJ, or in the camps also, definitely maximum patients, they can get the good vision, that is a 6x6. Now, who decided the benchmark? This benchmark was decided by the health mission, and this the National Health Services in 2004 decided that this is the benchmark, and benchmark is, you can say, the more than 90% post-operative within plus or minus 1 diopter. This is the benchmark till today, not changed. Now see, the refraction is, you can say, minus 1 diopter, or what went wrong. So why I can't see the last line? So this is always a question by the patient. And what I am missing, why I am missing this? It is because of the, you can see the checklist, measurement error, IOL calculations, or you can say in the calculation, it may be a estimation of the post-operative IOL position, determination of the post-operative refraction, and measurement of the axial length may be wrong. Because of that, it is not possible to go to 6x6. And to avoid the measurement errors, you should go with the non-contact optical biometry, or you can also go to the immersion ultrasound. And this immersion, though you are doing the non-contact biometry, it is very important to go for the immersion biometry in mature cataract and the posterior subcapsular cataract. And then repeated measurements by yourself, not by the technician, will definitely help you. Now see what happens, the IOL calculation formula. There are so many formulas you can see. But see, in both extremes, the only validative works when you are going for the both extremes. And if the eyeball is short, normal or long, you can have the holiday one, or the Hopper Q, or SRKT, you can go, or Haggis. These are the formulas where you must use it whenever you are doing the calculations. Then the IOL calculations, you can see here, all this formula definitely helps us. Now another thing is the IOL position and the alignment of the IOL. The size of the capsular axis has a direct relation to the effective lens position. It's very important, because this effective lens position, always you can see it may be a femto, we can cataract, zepto, or intraocular lenses, or intraoperative overlay. That always helps us. And here the capsulotomy, if it is a small size, that is less than 5.5, or the large size, what happens? You can get the anterior the capsular fibrosis or hyperopic shift if it is a small, and if it is a large, you will get the increase the rate of the tilt, or you can have the decentration. See here, the lower line says that a difference of 1 millimeter in the lens position can cause approximately 1.25 diopter change in the refractive error. It means the effective position of the lens is very, very important whenever you are doing the premium lenses. Now intraocular lenses, now there are so many premium lenses, the trifocal, accommodative, multifocal, toric, and now we are shifting gradually towards the EDOF. The corneal pathologies, when there is a corneal pathology there, you must also, that will also affect the visual outcome. You see all these pathologies, whenever you are operating, you should do it. Otherwise, there may be a endothelial gatte you have operated, and second day patient is a white eye. So that you will have to see. You can also have the retinal pathology. So in the retinal pathology also you can see the cystoid or any other pathology, and that is always you can say post-operatively creates a problem. Now the site, it depends on the sites also. So whenever you are taking the incision, then you must know the curvature, and according to the curvature you must slightly change in this one. And second thing is pre-operative counseling. Now this is the main important thing, that we are just promising very high. Yes, you will get 6/5, you will get n by you can say n by 5, n by 3, n by 1, and the patient is happy. Yes, you just implant the IOL and you can read and you can do everything. So this is the only one problem by the over promises, and this over promises, I think, don't promise high sky, because see, we don't know what is going to happen. So whenever you are promising, promise realistic, and once you promise realistic, patient may go to the other doctor, but for the second eye patient will come to you, because high promises, the nothing, no, we can't, I think, provide such type of thing to the patient. And in summary, you can say the accurate IOL measurement is very important. You must measure it properly. Then the second is the correct IOL selection. Then updating the IOL constant. We must update our IOL constant. Then the retinal evaluation, topography, and the patient counseling, what I said. Now the perfection is not attainable, but if we chase the perfection, we can catch the excellence. It is possible, we can do it, but sometimes see what happens. You will have to chase it, what has happened in my eye, what is my astigmatism, why it is coming, where was my incision, and what I will have implanted, how much my rexis. If you see all the factors together, then definitely you can attain the good result, and you can go for the 6/6. So always plan for the 6/6, but not early. Gradually you can learn and you can go for the 6/6. Thank you very much. And now we have got some time of the 2.5 minutes, and if anybody want the questions, definitely we can ask answer the questions. Thank you very much.
Thank you so much, Professor Lahane. It was a wonderful session on SICS, and one must consider monovision in giving the bifocality to the patient, which is so very essential. It's very cheap, and you can easily give 6/6 vision or 6/9 vision in the dominant eye, and in the other eye you can make them myopic, and you will not need glasses most of the time. So this is what you can add with the SICS, and one can do wonderful job with the SICS. Thank you so much, sir. Dr. Agni?
Thank you, sir. I agree with you. And thank you, friends, for being here for this session. And if anybody has to share something of their own or give tips to anybody, I think those are also welcome. Lahane sir, final words. Parikshit bhai, Santosh bhai, and then Lahane sir, final words.
I think the SICS is here to stay, and whenever I think you are operating with SICS, don't feel that you are inferior surgeon. It is one of the surgery accepted, that SICS, and yes, you can learn phaco, and those who are doing SICS, for them phaco is always better. So thank you very much. Thank you for I think sitting for 2 hours. Thank you very much.
So we'll take a group photo.
So even if you are a prolific phaco surgeon, you should be able to do SICS also properly.
I think
because SICS will bail out from any complications. So even if you are a good phaco surgeon, you should be able to do SICS.